to give a few more minutes to allow people to continue to call in, and then we will start the webinar probably around 3 or 4 minutes after the hour. Hello, everyone who's joining us. We're going to wait a couple more minutes to start the webinar and allow some other folks to dial in. Okay, it's a couple of minutes after the hour. I think we'll go ahead and get started, and others can continue to join as we go along. Welcome to IVI's webinar today on our model scope for major depressive disorder. We hope to give you a quick introduction to the model, talk a little bit about different stakeholder perspectives on how the model may be useful, and then get your questions and about the model and the scope, and hopefully prime you to provide useful feedback for the model going forward. Just wanted to ask everyone, if you have questions, to please post those in the Q&A section rather than the chat section here at the bottom of your screen. And first, I wanted to give a little bit of background on the purpose of the model and why we're concentrating on major depressive disorder, MDD. So we're developing this open source value model partly to look at major depressive disorder and treatments for major depressive disorder, but also as an exercise in creating open source value models. And we'll talk a little bit more about what we mean by that going forward. But we really see this as not only an attempt to do the best MDD model that we can and inform treatments in that area, but also as a platform for ways to explore methods of value assessment and ways to move the field forward for both MDD and other types of disorders. So next slide. Here's who you'll be hearing from today, along with me, and I'll introduce each of our speakers as we go forward. One of the things I wanted to talk about at the beginning here was, why are we focusing on major depressive disorder? Well, one of the reasons, of course, is the prevalence. Depression is something that can affect a lot of people. It's been estimated that nearly 17 million Americans experience at least one depressive episode each year. And depression is something, especially major depressive disorder, that impacts nearly every aspect of a person's life. And beyond that person, impacts their family, their employers, the healthcare system, and society at large in multiple ways. And so it's very important to look at the value of treatments in this area. And there's another interesting area, or aspect of this disease, is that there's a lot of different treatment options. So not just pharmaceutical treatments, but also non-pharmaceutical options, such as therapy and other treatments. And so it's a way to really look not only at drug treatments, but a larger, broader area of treatments, as well as different sequences of treatments. And so we're hoping to use this work to look at what are some of the things we can say about the value of treatments or sequences of treatments for major depressive disorder, as well as the value of different treatment approaches or treatment pathways. And one note I'll make here at the beginning too is we're going to try to use people first terminology and refer to people with MDD or people living with MDD. You will notice that occasionally our slides use the term patients where we think that's context appropriate, but we want to recognize that people living with MDD are more than just patients. Next slide, please. So just to reiterate the objectives of the model, we want to build a flexible, open source, and patient-centric model that will advance the science and practice of health technology assessment in the US context. So as I mentioned earlier, not just to look at this therapy area, but also to try to move forward the field of value assessment in terms of the methods we use for that. We also wanted to make it flexible and open source and reflecting the concerns of patients so they could facilitate multi-stakeholder conversation. We think it's important in any healthcare area, but especially in this one, to really get the viewpoint and perspectives of different stakeholders. And that's part of what we'll try to do during the webinar today. And the overall objective eventually is to inform the decision needs of multiple stakeholders in the healthcare system, including not just people living with MDD, but also employers, payers, and clinicians in terms of what are the best treatment options that are out there. So we just want to emphasize again, we're not building this model just for the model's sake or just for healthcare assessment, but also to really look at, how can this be useful to change the conversation around treatments for MDD. So a little bit snapshot of the model at the beginning here. As I mentioned, it's an open source value model. We think it's important for our models to be open source so that they're transparent. People can see all the way down into the source code and know exactly what the model is doing. And also so that people can see where the model may be able to change or be flexible in terms of different uses. As I said, we see this model development as a laboratory, so not only looking at this therapy area, but also an opportunity to improve the process and mechanics of considering value. And that there is important too. It's not just the mechanics or the methods that we're using, it's also the process. So do we have a fair process that solicits input from different stakeholders and incorporates that input in a meaningful way in the model? And you can see, again, our focus on MDD based on the prevalence and societal burden, as well as the evolving treatment landscape. It's also an area where we think there may be broad interest from multiple stakeholder groups. And then you'll see over here on the right, we see the model development as a team effort, and it has been to date and will continue to be so going forward. We've had a 20+ member advisory group, which has contributed to the model design from the very outset and will continue to provide input going forward. They've given us insight on patient preference research as inputs into the model, and as also importantly into the decision context or use cases that could be informed by outputs from the model. And they will continue to provide input on that and other aspects of the model, including helping us during these public comment periods to get good feedback from different stakeholders, as well as help us inform different use cases or applied research questions that we could answer with this model. Next slide, please. So now I will turn things over to Jessica Kennedy to talk a little bit about the perspective of people living with MDD. Jessica Kennedy is the Chief of Staff of Mental Health America. She developed and launched the Mental Health America's online screening assessment program in 2014, which is now the largest database of mental health screenings in the world. And fortunate to have Jessica here with us today, so I'll turn things over to her now.
Well, thank you, Rick, and thank you everyone for having us here today and including us in this value assessment model. And thanks to all the attendees for showing up. I'm Jessica Kenby. I work at Mental Health America. I've been there for about 12 years and have been really excited the past couple of years to get into the world of value assessment. And so I was thinking the other day about value because one of my friends has been searching for a new apartment, and it struck me that we make value assessments all the time, every day in our lives. When you think about apartment hunting, it's actually a really complex value assessment. There's so many inputs that we take in, all these variables of the cost, what's the size, is it 1 or 2 bedrooms, is it the location, what are the amenities we need, what are the amenities we want. And we all understand that everybody has different inputs. I have a dog, so the most important thing to me is that an apartment complex is dog friendly. My friend doesn't drive and doesn't have a car. It's more important to them that they need access to public transportation and walkable grocery stores. And so we all know that everybody has different perspectives on value in this scenario. And we have a lot of ability to drive the decisions in the decision context, right? We can go online, we can, look for reviews, we can tour a complex. And we really calculate all of these very complicated factors to come up with what we want for what we're willing to pay. And we do this not just with apartment hunting, but buying a car, shopping for flights, buying new shoes. But one of the only places that we collectively don't really do value assessments as individuals is in healthcare. And so I started to imagine, what if we treated apartment hunting like we treated finding treatment for MDD? If you want to go to the next slide. So instead of coming to the table with all these different inputs that that matter to me in these value assessments, I just go to a professional, tell them what my symptoms are. My current lease is ending. I need, want to have a roof over my head. And they say, you know what? You're definitely looking for an apartment. Going to look at your housing plan real quick. Okay, here is a standard apartment. We're going to give that to you and check back with me in 2 months and we'll see how things are going. And, we of course don't do that. That sounds kind of absurd, but this is the reality for many, people living with MDD. This is how the treatment process works for them. They go to a doctor, the doctor confirms their symptoms and issues, a treatment. There's not a whole lot of conversation unless the patient's really, really informed, educated, or engaged, and knows that they have the ability to bring up these concerns and the things they want to have covered. And when you really think about all this and you look at this, you say, we would never do this. Even if we didn't want to search for an apartment on our own, we would get a real estate agent who would do all those things for us. And so I think for me, it's a reflection on, just how missing value assessment and conversations about value are in the patient experience. If you want to go to the next slide. And this is why it's so important for patient advocacy organizations to engage. Value is really complex, especially when you're talking about healthcare. It's a really high barrier to understand what the different options are, how efficacious they are, what research says about what conditions something may or not be good in, the ability to go find and interpret real world evidence. And unless you know some of the terminology for what you're trying to look up, it's hard to even Google what you don't know. We're also in a context of healthcare where people throw the term value around a lot, but when they're saying value, what they really mean is cost. And for patients, that's especially true. A lot of times, the only thing that patients see and take as part of their health insurance is their out-of-pocket costs. But that's not a conversation about value. We also don't know what we don't know about value. We don't necessarily know everything that matters to every patient, to every individual living with MDD, until we start asking and listening. And it's one of the great things about what IVI is doing here is really listening to patients and individuals living with MDD. We can also we can collectively represent millions. We were talking earlier about how many people experience a major depressive episode every year. rather than one person coming forth, a group like ours can bring collective voices. And then one thing I think is really important to emphasize, especially in context of our focus on race and equity in 2020, is that patient advocacy organizations can really push forward agendas about equity and making sure that we're paying special attention to marginalized communities, to communities of color, to LGBTQ+ communities, and to people who live their lives at the intersection of different identities. And so these are all one set of arguments for why patient advocacy organizations need to engage. But I want to share what makes it really important to me and to the team at MHA. And so we were talking about MDD treatment the other day, and you can go to the next slide. And one of the colleagues at MHA, had said, oh, like, this is what it's like. You feel terrible right now. Here's something that may or may make you feel better in 6 to 8 weeks. I don't know, we'll find out. And what really struck me about that was the rawness of the patient experience. And there was frustration, and there's confusion, and there's anger. And it's not just about, we're gonna conduct research and find that the average time to treatment, is X years to Y years, but to really listen to the experience of people living with MDD and what that feels like. And we can do something really special when we bring those voices to the table, is we can transform healthcare. So it's not just about remission of symptoms and how effective treatments are at remitting symptoms, but how much we can change an individual person's life and make that person living with MDD feel better. And so I think some of the things that patient groups can bring to the table, like Mental Health America or other sister organizations that are working with this and other models, if you go to the next slide, is some of the kind of real experiences that people have with something like MDD that doesn't always get caught in traditional surveys or looking at symptoms. One thing that a lot of people with MDD experience, and if you know someone that they might find this very relatable, is how hard it is to clean your room or your house or your apartment. And it's also a daunting challenge where it's hard to clean it, and then the worse it gets, the harder it gets to clean it. You see this phenomenon on the internet where people are posting pictures of their depression rooms before and after. And what's really neat about being able to share that experience of this is what it means to live with MDD is then being able to figure out what that really means in terms of making an input or considering something. It's about motivation, it's about energy, but it's also something we sometimes miss because we'll focus on is the individual living with MDD able to go to work, because that's reducing disability costs. Cleaning your room, whether you do that or not, isn't necessarily going to change the disability cost, but it really, really makes someone feel better. And so the ability to talk about these things, the frustration with the delay in treatment, the fact that you want to go and socialize and hang out with your friends, but then you don't have energy, and then your friends stop hanging out with you because you cancel on them all the time, and now you don't have friends. And we know that friends are so important. And connections are so important for people living with MDD. And really understanding, being able to bring to that table just exactly what it means to live with MDD is what is going to help us shape a model of value assessment that is patient-centered, because it's about restoring the meaning back to the individual living with MDD and making their lives better, not just remitting their symptoms. So that is, that's why value is so exciting to me. It's so exciting to Mental Health America, is because we can really, really change how we do this.
Great, thank you, Jessica. That was it was great to get that perspective. And I'll just echo what you said in terms of the importance of patient advocacy organizations being involved in these types of processes. I know from personal experience conducting health technology assessments that there have been many times where patient groups have really opened our eyes to what would have otherwise been blind spots within value assessment. And so it's very important to have that input. Now we'll turn to a different perspective, the employer perspective, another one that's often undervalued or overlooked when we come to value assessments. And to speak to that, we're going to have Dr. Mohanad Kusti. Ned Kusti is a global physician executive with unique expertise on corporate healthcare benefits, serving a variety of employers. He's the corporate medical director for Pivot Onsite Innovations and also consults for several organizations on corporate management of COVID-19. And now I'll turn it over to you, Ned.
Thank you, and greetings, everybody. So yeah, to continue the conversation on some blind spots, I guess, I wanted to give you an employer's perspective on this model. So let's go to the next slide, please. You know, we see the majority of people, at least in this country, get their health insurance through their employers. This is something that we know for a fact. And large employers are typically self-funded, or what we call self-insured. And what that means is that they are actually the true payers. When you talk to people, often the misconception that the insurance plan is the payer, when in fact the insurance plans act as almost like a third-party administrator, and the employer is the final person or organization paying the bill. Employers have a major role in health plan and benefit design, including medical, pharmacy plans, and wellness programs. So I think it's important to have the employers part of this discussion because of this fact. And the model would not only be complete, would not be complete if we did not engage in the employer's perspective. And in many situations, when looking at research and what recommendations come out, not just for MDD, but for almost a lot of medical conditions, the occupation or the individual's occupation or job may not be taken into consideration. So, for example, if someone has MDD that is not controlled or maybe undiagnosed, or on the other flip side, if somebody has it and is on a treatment or medication that may cause some kind of neurocognitive impairment, both of these reasons could lead to somebody being off work, lose their job potentially, or have an extended disability time, which are all kind of a catalyst to worsening that the MDD situation. Next slide, please. So, when talking about, the impact, I'm sure a lot of you already figured this out, but, when we talk about productivity, this condition specifically has significant impact on absenteeism, presenteeism, disability time, as mentioned, return to and days away from work. This also could impact the employer's talent retention and acquisition and affect, the number of job loss. Healthcare costs also is a huge impact. And, typically for these self-funded companies, the healthcare cost really affects their bottom line, their business bottom line. And we do see significant, maybe not large employers, but smaller employers may go out of business because they could not manage their healthcare costs. Many employers are trying to reach population subgroups and minorities as part of their corporate strategy. So there's also that stigma towards workers that are being associated with depression and any kind of mental health disorder. And there's also that impact on safety, especially for workers who work in safety sensitive jobs, that, whether, again, the disease being undiagnosed or uncontrolled, or if they're taking certain treatment medications that could cause cognitive impairment, that could impact their ability to do their job safely. Think about, the pilot that flies the plane, or the train engineer that operates the train, or that driver that's driving the 18-wheeler on the highway, or driving the bus in the city. So there are certain situations where the type of job does matter, and we in the occupational medicine world would often make different recommendations that would be made to the general public because of the fact that that person works in a safety sensitive job. So just wanted to give that perspective. I know this was short, but hopefully we'll have more discussion in the Q&A section. Thank you.
Thank you, Ned. And it was great to get that employer perspective. And, I know one of the frustrations that we often have doing these assessments is we know productivity is important, but we don't always have the data to populate the assessments for this. So, hopefully we can discuss that more later on. And I just wanted to give another plug along with Dr. Costes to please start thinking about your questions and typing those into the Q&A at the bottom of the screen. Now I'm going to turn things over to Richard Shee, who's a research manager for HEOR, Health Economics and Outcomes Research at IVI. And he's going to do a brief description of the model, kind of a snapshot, as well as what we see as the scope of the model to date. Richard?
Thank you so much, Rick. Good afternoon, everyone. It's a great pleasure to be here. So for my part of the presentation, as a member of the project team, I really want to give everyone a quick overview of the model scope. And along the way, I hope to highlight some important considerations and features of the model. And again, this is really built on our 8 months of stakeholder engagement with thought leaders such as Jessica and Ned. And we try to incorporate these considerations as much as we can. All right. So as Rick mentioned, the overarching objective of the model is to build an open source, flexible, and patient-centric model that can cater to the decision needs of a wide range of stakeholders in the US context. However, along the way, we have also identified some specific questions that we seek to explore throughout the modeling process. And here on the slide, I just want to highlight a few of these specific questions for you. And these specific questions have actually really helped in terms of thinking about the specifics of how we design the model. So first, for people living with MDD, what key factors define the value of an intervention? What is the relative importance of these value factors? Second, what are some promising methods to develop value assessment models that could reflect patient-defined preferences? For example, patient preference-based health utilities, multi-criteria decision analyses. Thirdly, how can the model support the decision needs of multiple stakeholders, here including clinicians, care providers, payers, and employers in comparing the value of various interventions? It is with these guiding questions that we have arrived at an initial model scope. And if you look at the appendix of the model scope document with very detailed documentations of these specific questions that we hope to shed a light on. So now, the first core component of our model is the health economic model. So here, I want to give you a quick snapshot. One thing I want to note though is as you read the document, you might notice that we actually include a lot more specifics than what you typically see in a model scope document. So right now, we're really kind of in between the scope and protocol stage. So just think of that as you read this document. All right, so the model is really focusing right now on the treatment-naive adults of age 18 to 64 who were diagnosed with MDD by a healthcare provider. So this specific patient population was actually based on the feedback from our multi-stakeholder advisory group on the need to really focus more broadly on the general MDD population. And also our first step is to focus on those who might be actively employed because of the productivity impact. However, one thing we want to note is the model itself is designed in a very flexible manner, so it can be easily adapted to different population groups. For example, those of age 65 and plus. For this model, we're really interested in capturing the patient experiences in all settings of care in the United States. So by all settings of care, we mean primary care, specialty, and telehealth, which has really gained increasing popularity during the COVID era. And again, this is based on our literature findings and also feedback from the advisory group that the settings of care can really impact the treatment interventions and the treatment outcomes of patients. And in our base case of the model, we'll feature societal perspective as the base case. And what that means is we're capturing a comprehensive set of benefits and costs, regardless of who bears these costs in our healthcare system. And of course, we'll also provide the flexibility to customize the input and output based on the interest of a very specific stakeholder perspective. So for example, from the perspective of an employer purchaser. And in terms of the model structure, consistent with the previous open source models, we're featuring an individual level simulation. And this way we can better account for patient heterogeneity, and also this could enable subgroup analyses. In terms of comparators or the treatments that we seek to evaluate in this model, the model will provide a flexibility to do both treatment versus treatment comparison, but more importantly, the comparison of treatment sequences. Because we all know how complicated, as Jessica mentioned, how complicated the real world treatment patterns is for a disease like major depressive disorder. So we found that it's really important for us to capture the patient journey across these sequences of treatment. And of course, along this journey, we'll also include a wide range of pharmaceutical and non-pharmaceutical interventions. Now, in terms of time horizon, we're aiming to simulate the patient outcomes over a lifetime horizon. But of course, it also comes with the flexibility for users to study outputs at interim time points. In terms of the outputs, we're also giving the flexibility to present a range of different economic and clinical outputs. So instead of just showing, let's say, cost per quality as one composite measure, we're really showing the disaggregate measures, such as the total cost, the time in certain health states, for example, to really a wide range of them. And then lastly, I want to highlight 3 key considerations that we're evaluating, and again, based on the input from our AG. The first one is productivity, as Ned has very eloquently described of the different channels of the productivity impacts. Second is adherence. So adherence has a big impact in terms of the effectiveness of the treatment, and then the downstream economic and clinical outcomes. So we're looking for ways to incorporate that into our model structure. And then lastly, one thing we have identified in the literature and also stakeholder engagement is that a lot of patients who are diagnosed do not initiate treatment actually in probably 6 or 1 month after the diagnosis. So the delay in starting active treatment actually has some consequences in terms of clinical and economic outcomes. And that is something we aim to incorporate in the model as well. Well, I know I'm flying through all these specifications, but I hope this gives you a sense of what we're trying to accomplish in the health economic model or module of the MDD model. So 2 things to really highlight for you. 2 features we're really trying to incorporate and build into the model are, first, flexibility. So instead of giving you the best or the most suitable design, we're trying to give you sort of the flexibility to evaluate different assumptions. And this way, different users can really see what are the implications of using different inputs, assumptions, and what that means for the outputs and the decisions. Second is, as Rick mentioned, this model would be fully open source. And what that means is all the back-end source code, everything will be fully transparent. And this way, we're hoping to achieve 2 things. One is maximal flexibility, depending on the decision needs of specific decision stakeholders or perspective. And then secondly, through greater transparency, we also hope that this could increase the buy-in or the use of economic evidence in health technology assessment in the US setting. Now, so health economic model is an important part of the MDD platform. However, as a laboratory for testing novel methods, I also wanted to mention some of the key themes that we're trying to test in these models, in this model, MDD specifically. So these areas are, first, we're trying to find ways to quantify and incorporate novel elements of value into the model. So productivity is one of such examples. Second is, instead of just looking at clinical trial data, which is usually more commonly used in economic models, we're also trying to find sources of real world data and incorporate them into our model wherever possible. So that's second area. Another area is, in addition to health economic modeling, we're also hoping to test alternative decision analytic framework. And one specific framework that we're hoping to test here is the multi-criteria decision analyses, which has actually been commonly applied in a lot of ex-US HTAs. So, and for those of you who are new to MCDA, what MCDA does is it allows the decision makers to consider a wider range of decision criteria and also the weights of different criteria and evaluating different alternatives to a decision question. So these are the additional 3 areas that we're really hoping to test. Now, I think the 2 other things we really want to share with you is, as Rick mentioned, the patients and the employer perspectives are very important, but oftentimes are underrepresented in the past health economic modeling or health technology assessment. So what we're trying to do in this model is to also incorporate and bring those voices forward. So Jessica has described the many ways in which the patient voices should be added to the value assessment process. So how are we doing this in terms of our MDD model? So here are at least 2 ways we're doing this. One is through our continuous engagement with the patient stakeholders, members in the advisory group, such as Jessica. We make sure these inputs are reflected and incorporated into our MDD model. Additionally, we also have a study that's conducted in partnership with our colleagues from the PAVE Center at University of Maryland. So far, we have conducted 20 interviews, one-on-one interviews with people with MDD. So the interviews really gave us insights for 2 things. One is the impact of MDD and MDD treatment. Second is, what are the key value factors that people with MDD consider in evaluating potential treatment options? And with these inputs, we're hoping, in the subsequent phases of model development, we can explore novel ways to systemically incorporate patient input into modeling and HTA. So in terms of economic modeling, we're hoping the patient input could inform utility inputs into the model. We're hoping that in defining the clinical economic outcomes, they're consistent with real world patient experiences. And in terms of the MCDA, the patient inputs and priority could directly inform the criteria and weights. So these are some of the areas we're testing and hoping to bring patient inputs directly into modeling. And similarly for the employer perspective, to better address employer decision needs, we are continuously engaging with employer stakeholders such as NED in the advisory group. And currently we're thinking of at least 3 ways in which we're doing this. First is, as I mentioned, the impact of adherence on effectiveness and downstream clinical and economic outcomes. The ability to conduct subgroup analyses, which is an area that's increasingly a concern for our employer stakeholders. And thirdly, how do we really capture productivity impacts? So absenteeism, presenteeism, these are the things that were probably featured in past economic models, but we have to go a little beyond that. So here we're also looking at short and long-term disability, workers' compensation, fitness for duty. So I hope by now I have given you sort of a quick overview of the model scope and some of the highlights for our model. And again, we really encourage you to read the model scoping document, which includes more details of our consideration. And again, we really welcome your feedback in terms of shaping our thinking about the model scope. And one thing we want to emphasize here is we just want to be really comprehensive in terms of assessing the different considerations for different model specification. So we really welcome your thoughts, make sure we are comprehensive. So with that, now I'm going to turn over to Rick.
Thanks, Richard. That was a nice summary of the model. And now I'd like to open it up for Q&A, and I'll ask our panelists to please start their video back up. And if you could go to the next slide, Richard.
Sure.
Just wanted to put up some of the potential users and applications of the model that we've thought of so far. And you can see there are multiple stakeholders represented there, and multiple ways to use the model, and many that aren't on this slide that we could have put there. But I also wanted to ask, Jessica and Ned, from your perspective, we've heard a little bit about this, but what do you think are some of the ways that patients or people living with MDD and their family or healthcare providers might use the model? And then for Ned, what are ways that you think employers might find the model to be useful?
Well, thank you, Rick, for the question. So to talk about people living with MDD and their families and their caregivers, and think about some of the things that we do at Mental Health America. So we have our online screening program where we give free, anonymous, confidential mental health screens. Part of the reason that we do that is because although we know screening should be used in all primary care settings and all, doctors' visits, they aren't always conducting, giving these screens and mental health assessments. So what we do when we provide these free, confidential, anonymous tools that someone can then go take to their clinician or to their provider to start that discussion, kind of, flipping the power dynamic and giving the actual individual with MDD the power to say, hey, you didn't ask me, but this is something that's on my mind. And I think are really cool, because it's going to be open source and flexible. It could be something we could give a decision aid to an individual with MDD, maybe somebody who has just taken our screen, to say, you can go. And by the way, you don't just have to, say, hey, I need treatment. You can say, and here's a script or a decision aid for, these are the things that matter to me. Let's discuss which option fits best.
Great, thanks.
And yeah, from an employer and occupational perspective, one thing the patient can do is make sure that the provider understands the full scope of their job, and when treatment options are being discussed, that is definitely taken into consideration. Now, for the employers, as you engage employers, and as I mentioned, there's plans designs, there's also opportunities of adding additional resources for employees who are or family members covered under the plan for those who have this diagnosis, such as different wellness programs or mindfulness programs that can be offered. There's also consideration specifically on the subpopulation that we talked about and minority groups within these organizations, and be able to understand that the access to healthcare may not be the same for everybody. We know from data showing that minority groups typically have less percentage of access to healthcare or to specialists that can manage difficult chronic conditions. We also need to keep in mind that when these individuals are going on disability and then coming back, that disability time may be different depending on the disease and condition, and whether they're remaining off work or being returned to work. That needs to be, again, the occupational and the type of job needs to be taken into that discussion, and make sure that both the employer and the healthcare provider are all understanding what this individual has to go through when they wake up every morning and go to their job.
Great, thanks. That's I think what I'm hearing from both of those answers is this could actually help with communication between particularly people living with the disease and their healthcare providers. One question we've got, and I'd like to again plug our Q&A. Please, any participants have any questions, go ahead and type those into the Q&A section at the bottom of the screen. But one question we got, and this is probably for you, Richard, is what is the rationale for limiting the target population to the 18 to 64-year-old age group?
So I think the main consideration there was at the time mainly due to, one is the insurance coverage consideration, because the 65 plus could very well be covered by Medicare, and that require a set of different inputs. So that's from a feasibility standpoint. Second is again, productivity and the impact of that, which is something we want to feature. Not to say that people above the age of 65 are not engaging in employment or so on, but it's usually more that people in the age range of 18 to 64 would be more engaging in full-time or seeking employment. So those are some of the reasons why we pick 18 to 64. But however, this doesn't prevent us, from applying this model to those of 65 and older. And in fact, that is something we do plan to do once we get the version 1.0 ready. And we don't foresee that, the model structure itself will change a lot, because hopefully a lot of the clinical outcomes, economic outcomes would generally be applicable to across different age groups. So we do hope to expand and also cover those of 65 and plus.
Yeah, thanks. And yeah, I think we could do a whole webinar just on how do you value time for people who are not in the workforce, because we do recognize that even if you're not getting a paycheck, you do have productive time that is contributing to society. On a related question, we also got a question here about the rationale for starting the treatment naive patients. So I wondered if you could address that as well, Richard.
Sure, absolutely. So this is a really interesting story, because when we first start conceptualizing this model and before engaging with our multi-stakeholder advisory group, we're actually thinking about focusing on the treatment-resistant population. So because from what we read in the literature, that seems to be the subgroup that actually incurs the most societal burden. So that's what we thought. But however, through engaging with our stakeholders, there are several things we learned. One is treatment resistant itself is not a very well-defined term per se. So there's no consensus about what that means. Actually, a more commonly used term should probably be difficult to treat, or those who failed 2 lines of therapy after initiating treatments for MDD. And the second thing is because our stakeholders really emphasize the need to look at the holistic treatment pathway. So how do patients get to the so-called treatment-resistant depression? Because there's so much value, so much more that we don't know before they get to that stage. So it's really important to really model that entire treatment pathway. And so to understand following their treatment initiation. So because the earlier part, if we treat them right, if we have more insights about what can be done right, maybe these patients never have to be in treatment-resistant state. And I know I use the word patient, but but you get what I'm saying. And another thing is, if I may say a third thing, is that our current model setup can actually also allow us to study those who have failed 2 lines of treatment. So for example, because we actually, right now, our thinking is to simulate up to 4 sequences of treatment. So one way we can think about it is maybe after patients did not achieve adequate responses after a complete courses of treatments, that patient subgroup could be considered as mimicking the treatment-resistant depression.
Thanks, Richard. Yeah, I think those are all good points. And again, as part of the model, starting from treatment naive, if we do want to look later on in later versions of the model at patients who have had 1 or more treatments, we'll be able to do that. For treatments that have failed patients, we'll be able to look beyond those. We've got a couple of other questions coming from the participants, and I think they kind of relate to a question I had queued up, so I think I'll go ahead and do that, which is, one of the things you mentioned, Ned, was differential access for minority groups or others. And so, I wondered if you or Jessica had any thoughts about ways in which, or Richard, in which this model might be able to address issues of equity or access for different groups.
Well, the hope is, first of all, I identify and educate people that this is an issue, like not healthcare access is a significant issue for different subpopulations. And I think that's the first step, is to identify that part of the challenge. And then the second thing is, let's talk about from an employer perspective, maybe that subpopulation can benefit from other modalities, like as I mentioned, specific targeted wellness programs or mindfulness programs, or as mentioned earlier, utilizing more of the telemedicine technology and try to eliminate that barrier. But however, we have to keep in mind that within that population, sometimes technology is not available. So in the plan design, for example, when you're talking about, and I personally had to go through this in network versus out of network, and sometimes the patient is being charged or penalized more for going out of network, when in fact that was their only option. Like the first or the nearest in-network provider would be like 3 or 4 hours away, and that's obviously not helping somebody with a disease like this, who can barely get out of their house and barely push themselves to do certain activities, to even require them to drive 4 hours. So in that situation, the employer should be cognitive and give I don't say the word a pass, but basically treat it in that situation, have at least in the plan scenarios where if this is an issue, it can be dealt with, as opposed to letting the patient just struggle and go into circles with the health plan TPA and not really resolve their issue. I can tell you personally, I would for companies that have a corporate medical director, I would get involved and evaluate the case and then provide a recommendation that closer distance out of network provider would be considered as if they were in network, and that way we can resolve that issue. So that's just one example of how this is a challenge for many subpopulation groups.
Yeah, and I think what's really cool about this model is its flexibility in the multi-criteria decision analysis. Because one of the traps we fall into is society and in health policy in general is when we treat patients or people living with MDD as a homogenous group, there actually are sometimes very significant differences in how subpopulations experience, talk about, or value MDD. One thing that we have looked at is there's research that shows that people who identify as white are more likely to describe feeling hopeless, nervous, restless, and worthless, where people who are Black say everything is too much effort and they're sad. And so if you're thinking in the context of productivity, you have restlessness versus everything is too much effort, which can both impact productivity, but they're different expressions of a similar concept. And so when you have a value, of something that's flexible, if one community or one individual cares more about family and one cares more about friends, this is something that will, adapt to different cultures and to different preferences. So I think that's a really exciting opportunity here.
Thanks. Thank both of you. Richard, before you answer, maybe you can add on to your answer. Jessica mentioned subgroups that may be important. And one of our questions has been about people with substance use disorder or patients suffering extreme anxiety, maybe certain subgroups that would be important to look at. So I know we've talked about that in terms of the model design. So I wondered if you could address that.
Sure. Actually, let me address the first question, which is the subgroup analysis. So a big shout out to Jessica, who actually that what I was about to say, which is that we understand the differential impact of the disease preferences across different patient subpopulation. So that is why we're trying to build in flexibility. So this way, when the data inputs are available, we can build them into the model. And this way, we can really generate insights that are tailored to specific subpopulation. Of course, in parallel to that, we're also planning for studies such as the patient preference study, which I briefly mentioned, one objective of the study is actually to look at patient heterogeneity in terms of preferences. And is that really a thing? Because from a lot of anecdotal evidence, we know they really differ. How do we put it into quantitative inputs to inform the model? So again, so the flexibility of the model structure really will help us prepare for subgroup analyses and also differential impact or program evaluation that target the more vulnerable population of our society. And now the second question, Rick, you just mentioned, is that people with other comorbidities, and these are comorbidities that could be chronic conditions or other types of mental health challenges. So actually, we are aware of the burden for that group of the population. And right now, we're not specifically addressing that in the first version of this model. However, it is our intention that as we build the base, the version 1.0 of this model, and next year, we'll actually look into a subpopulation which also suffer from other types of chronic diseases, or other types, including other types of chronic mental health conditions. And one thing I should quickly mention, though, is even though we're not explicitly modeling the impact of MDD treatment on non-MDD conditions or health or well-being, we are capturing that to an extent in terms of the cost. For example, we're looking at costs that are MDD related and non-MDD related. So that would be the first step for us to get there. Yeah.
Thanks, Richard. That's helpful. And I know, part of the reason we're building the model as a patient level simulation is to give us some of that flexibility to look at different patient subgroups and be able to, slice and dice in different ways. So I see we're getting close to the end of the hour. So I wanted to say thank you to Ned and Jessica and Richard for taking part in the webinar. And I want to thank all of our participants for listening in and for your questions. If you could go to the next slide, Richard. Just want to talk about some of the next steps and the timeline here. So as we've just been talking about, we're in the public comment period for our model scope document, and that public comment period will end on May 14th. And we encourage you and any people you can send this to who may be interested to submit comments. We will then incorporate all of those comments, go through them, try to use them to modify the model when appropriate. And then we will be creating next our model protocol, which Richard mentioned earlier. This is a more technical document, which will have more details on the actual model structure and health states, the actual data inputs and sources for those that we're planning to use, the assumptions that we will need to make for the model to really be able to reflect reality, and some of the output or outcomes that will come out of the model so that people can see what they can expect in that area. We'll also have a public comment period on that document where we'll be soliciting comment in terms of things we may have missed, data gaps, data sources we're not aware of, assumptions that people may want us to make rather than ones we're proposing. And then following that, we will go on to develop the actual model, planning to have the public release of the model after validation in early 2022. And along with that, both during development of the model and afterwards, we'll be developing different use cases or applied research questions that the model could be used for. And then afterwards, as Richard mentioned, we'll be thinking about future versions of the model in different subgroups or different modifications that we may want to make to the model going forward. And I just wanted to reiterate, the real purpose of the public comment period on the scope is to get feedback in three main areas. We want to hear about the assumptions and data elements that you think are important to include in the initial model design. We'd especially like to hear about patient important factors that would be important to include in the model. And third, if there are any specific use cases that you think we should build into the first edition of the model. So in other words, research questions that you'd be particularly interested in, or decision problems that you'd be particularly interested in informing using the model. We'd like to hear about that. Next slide, please. So now our ask is that you please submit comments by May 14th. As I mentioned, that you please share with your colleagues at both the scope itself and the recorded webinar, which will be available on our website. I want to remind you there are two ways to comment. You can submit an email to thevalueinitiative.org, or you can respond to a survey at this link here, depending on which is easier for you to submit your comments. And with that, I'll close the webinar and say thank you to everybody who participated today, and we look forward to getting your comments.